want to add my welcome to all of you to our second annual meeting, also to thank the sponsoring organizations, and also to thank our host organization, the California Endowment, for the conference space. So we're now moving into the second half of what I guess is our first component of the meeting. I'm trying to keep track of the different components. So the program was all very carefully designed. Our ultimate goal, as you know, is to try to increase the amount of partnership-oriented implementation and improvement science, but also the benefits, the value of that activity. And we thought that we would do this by allowing you to hear from some of the key agency leaders who would share their commitment to this sort of work, and allow especially those of us who are researchers to understand that we have willing partners. We'll also have a second round of case study presentations to continue to show you some of the richness, the breadth and the depth of this kind of work that's underway. We had our skill building sessions this morning, and then at the very end of the day we'll have some project planning sessions, and I'll say more about those in a minute. I'd like to just ask you again to be sure to fill out your evaluations, as well as the social network forms that we've given you. And I think the evaluations are purple in some packets and yellow in others, and they may be other colors, so watch for those. Let me turn the podium over to Greg Ahrens, who is UC San Diego, the UCSD representative on the planning committee, and he'll introduce this next set of speakers.
Great, so it's my pleasure to introduce our next panel of speakers. And I'll start here with Alfredo Aguirre, who's the Director of Behavioral Health Services of San Diego County. Served in that capacity as Mental Health Director since 1999. He's on the Board of Directors of the National Network of Social Managers, and as co-chair of the Cultural Competence, Equity, and Social Justice Committee of the California Mental Health Directors Association. And he's worked in mental health field many capacities over 34 years as a psychiatric social worker, a staff supervisor, manager, and executive. So he knows the multi-level landscape in that setting. And then Martin Serota, MD, is Vice President and Chief Medical Officer at Altamed Health Services, and he's going to describe what Altamed is when he gets up here. But it's a fully accredited, federally qualified health center serving Southern California. And his priorities are creating a patient-centered organization, focusing on patient experience and quality outcomes, and works to improve operational efficiency, utilizing health information technology and innovation. And then at the end of the table, Michael Gould, MD, is a pulmonologist and health services researcher with a long-standing interest in the care of patients with respiratory disease and lung cancer. He's Director of Health Services Research and Implementation Science, and leader of the Care Improvement Research Team, or CERT, in the Department of Research and Evaluation at Kaiser Permanente, Southern California. And so, without further ado, I'm going to ask Alfredo to kick it off. Great.
Good afternoon. It's great to be here. So what I'm going to try to do in my 15 minutes or so, and who's the timer, Greg? Who's going to keep me on? Oh, here we go. I'm going to talk more about the public sector's an example of public sector partnership with researchers and evaluators, and improving our behavioral health system in a large county. I'll give you a little bit of context of the county. I'll talk about the purpose of this important collaborative effort, the history of our partnership, a little bit about a research committee that we have, examples of fidelity and performance improvement projects, and then talk a little bit about the future with some exciting new innovation projects we're going to be rolling out. So to give you a little bit of a context, Behavioral Health Services serves 75,000 individuals, adult mental health, children's mental health, and alcohol and drug services. Our services include long-term care programs as well as inpatient care. We are the specialty mental health plan for Medicaid beneficiaries in our county. As you know, the county public mental health system is a county-driven system compared to other states. Again, we're part of the Health and Human Services Agency. We are really driven by a 10-year transformational effort called Live Well San Diego, which is right there behind me. And It really started out in 2010 under the Health and Human Services Agency, but it has branched out to other groups in the county, including our public safety group and land use and environment group. There's 3 major domains or pillars to living well or Live Well San Diego. One is building better health. It really calls for the improvement of improving the health of all residents and supporting healthy choices. Living safely calls for ensuring that residents are protected from crime and abuse, neighborhoods are safe, and communities are resilient to disasters and emergencies. And our final pillar is thriving, calls for cultivating opportunities for all people and communities to grow, connect, enjoy the highest quality of life. So when I think about our collaboration with researchers and evaluators in our county, really it's two-pronged: to work collaboratively with community researchers and to engage the community in the implementation of research activities, and to constantly strive to learn more about best practices and strategies to working effectively with our consumer populations at our various program sites. And when I talk about the area of research, I'm really going to expand out and talk about the important evaluation efforts and performance improvement efforts we've had in the county. So a little bit of background to our partnership. In 1990, we have a partnership was established between the Child and Adolescent Services Research Center. I'll talk a little bit more about them, and Greg has been part of that distinguished group, and San Diego County Behavioral Health Services. I'll talk a little bit about when our research committee was formed, and then going on to 2002, really establishing a partnership with the University of California, San Diego, UCSD, and again, the County Behavioral Health Services division. At the time was mental health. We have now integrated with alcohol and drug, and we are County Behavioral Health Services. So with CASRAC, just to comment on that, again, the Child and Adolescent Services Research Center, the most important work was establishing an annual system of care outcomes report. And this was a snapshot of the entire system, which gave us not only demographic information, but outcome results. As the years went by, we improved on the data and used the report as a major report card for our performance in our children's mental health services. The report continues to be used with stakeholders, advisory boards, and state audits. Again, this is really about reinforcing our county's commitment to accountability. Our partnership with CASRAC provide opportunities for in San Diego to advance the quality of mental health care, implement specific evidence-based practices, and collaborate with CASRAC investigators in the dissemination of relevant practices. Just commenting a little bit more on CASRAC, they were an NIMH-funded funded research center, and they had that funding for over 15 years, and now CASRAC supports themselves with research grants, and they will be seeking a National Institute on Drug Abuse, also known as NIDA, center funding. So as we developed our evaluation for both children and adults, CASRAC continues to do the work for children, and our Health Services Research Center out of UCSD does that work, similar work for adults. And also, one thing I want to mention that CASRAC has also done other types of evaluation studies, including our Salud program, which addresses the interface between diabetes and depression in our Latino community. CASRAC has served on committees and work groups for the county. Some example of that is our dual diagnosis committee, and also CASRAC investigators have also worked with the county on specific initiatives, our prevention and early intervention programs, and respond to the need for information and inform county decision-making on service needs. I'm going to go back, sorry. A little bit about UCSD, again, was established in 2002. Over the years, again, both partners have benefited. We benefited from obtaining resources, including time, information, access to technical and scientific expertise, and UCSD investigators are able to study diverse populations, acquiring real-world information to guide the development of interventions and services, and developing insight and opportunities for improving community practice. It's also provided opportunities for San Diego to participate in various stages of research, need assessment, study design, implementation, interpretation, dissemination, and implementation of the results, especially in the area of geriatrics. Specifically, the work has been, the bedrock for this work is at the center called the Advanced Center for Innovation in Services and Intervention Research, ASSISR, at UCSD Department of Psychiatry. It was also originally funded by an NIMH Research Center grant. And again, the mission of this group was to improve the quality of life of middle-aged and older people with schizophrenia and other psychotic disorders through the development, implementation, and dissemination of evidence-based practice through community partnerships. The engagement of community stakeholders, consumers, caregivers, and care providers, as well as the expansion of community research capacity, is a very important focus of this research. Currently, we have 38 open research studies that are active with San Diego County Behavioral Health Services. Our research partners include local researchers, non-local researchers, external agencies, and graduate and doctoral students. Again, I talked about our focus, our major collaboration with UCSD Department of Psychiatry, and by the way, CASRAC has evolved, has become part of the overall UCSD movement. And there's a number of other research partners, including Rady's Children's Hospital, Sharp Mesa Vista Hospital, San Diego State University, USC, and it goes on and on. We have some national collaborations with the University of Washington Department of Psychiatry for a program called PEARLS, which refers to encouraging active, rewarding lives for seniors. It's a fidelity study, and it's an evidence-based practice to reduce depressive symptoms and improve quality of life. We also have a partnership with the University of Nevada, Reno School of Community Health Services. This is to study the trends in heroin addiction by treatment admission in San Diego County at the various programs we have in addressing heroin. And with Boston University College of Health and Rehab Services, this is developing an instrument to measure recovery, promoting competence among Latino mental health providers. I'm not going to go on too much. You're all very familiar with the research committee. We did form this in 1994, and what I do want to mention is when I think about ways that we can improve our connection with the communities, when I look at my research committee in the county, which reviews all research studies that are being advanced, is that it's all internal. We do not have any community partners, and for example, consumers, people with lived experience. That's something that I want to change. Actually, UCSD has done a better job in that area in involving members of the community, actually, again, people with lived experience. And again, I think it's important. What we do now, anyone who's presenting a research study, we meet monthly, by the way, but they're required to present their research to the committee, and that brings everyone to the table. And so that was started in 2013. And also allows the researcher to go back and make second course amendments or changes in their research study to be approved by the committee. Again, I could go on. The benefits that has advanced our county's behavioral health system, again, it's enhanced the collaboration between the community and national research partners. It's improved understanding of factors that contribute to efficient and ongoing assessment, monitoring, and improvement of behavioral health clients. It also builds towards future research in behavioral health, focusing on client recovery and resiliency, and advances the knowledge of evidence-based behavioral health theories, fidelity models, and research to practice. We have a number of examples of fidelity model. One I do want to comment is the assertive community treatment model, which is a team-based treatment model, provides multidisciplinary flexible treatment and support to people with mental illness. And one of the things that the studies of the assertive community treatment has shown nationally in terms of people involved in this kind of practice is the reduction of hospitalizations by 20% pre-receiving the practice and post. Those are actually national measures, and our measures locally are actually better than that, where we're actually close to 60% reduction in acute-related services that include emergency psychiatric, crisis, residential, and hospitalization. Just want to move on here because I know I'm running out of time. So I do want to, we talked about some of the fidelity models here. I do want to mention, go back. We also have a program that I mentioned earlier, the PEARLS Fidelity Study, that was implemented to address communities of color, their elder community, in those, the elder community, around a program that's called EMAS. That's our operationalizing the PEARLS study, Elder Multicultural Access and Support Services. It's a peer-based outreach program that provides services designed to address mental health issues, provide prevention activities, and increase access to mental health. And again, what we have found with that program is it's very similar to the adult day model, that maybe day health model that you may be familiar with, but we have found it to be more culturally competent, and what the recipients of the service have told us is they feel more comfortable in the EMAS programs, again, based on the Pearl program. I also just quickly want to mention looking at, again, models where collaboration has improved our system. We have a big initiative called the Prescription Drug Task Force in our county. It's recognizing the misuse of prescription pain medication as a serious health threat. We have a coalition that's built on, again, what the information is telling us around prescription drug abuse. It involves the district attorney, sheriff's department, district drug enforcement administration, the county medical society, and other key stakeholders. What we developed is safe prescribing guidelines, and that's online. You can just, if you're interested in it, you can access it via online, and it offers important public information to patients regarding prescription medicine safety. And it's been adopted by all 19 emergency departments in San Diego. So finally, I want to mention, some of you are familiar with the Mental Health Service Act. One of the components of the Mental Health Service Act, also known as Prop 63, is to usher in innovation through a category it's called innovative projects. And over the years, counties have adopted these or have implemented these innovation projects, or 3-year projects. We have over 10 of them active, and we're adding a few more, which is pretty exciting. They're on the screen in front of you. For example, we're going to be implementing a faith-based initiative, something called Innovative Mobile Hoarding Intervention Program, a program for young adults and teenagers called Urban Beats, looking at the role of dance, music, and art in healing with young people. And we have a number of other programs. What's important to note here is that what's expected is we are to document and work with evaluators to document the outcomes of these practices for future adoption into our system of care, or to take elements of those programs and make sure that they're implemented in existing programs to improve the care of the people we serve. So finally, if you have any questions, I'll be hanging out a little bit afterwards, and I'll be here for the questions that certainly that Greg moderates. So thank you very much.
Good afternoon. My name is Martin Serota. As mentioned earlier, I'm the Chief Medical Officer for Altamed, and I've been there for 5 years. My presentation will be a little bit different. I don't have any slides, and I'm going to be talking about how leaders can drive research at their institution and how researchers can make themselves attractive to institutions like ours. And my take-home message is that for a research department to be really successful, at least in our organization, it really has to be really tied to the strategic mission of the company. So I'll talk a few minutes about our company and our strategy, and then hopefully this will all tie together nicely. So we'll do an Altamed overview, a history of our research activities and how we've improved those activities in its current state and where we're headed. Altamed is the largest federally qualified health center in the nation. We take care of the underserved. Most of our patients are Latino. We have about 200,000 patients. We do about 1 million visits a year. We have revenues about $400 million a year. So again, most of our patients are Medi-Cal or uninsured, but we do take all payer types. We have clinics in LA County and Orange County. We have 24 medical clinics, 8 dental clinics. We also have PACE sites, which is a program for all-inclusive care of the elderly. So we have that population we take care of as well. And we have 2,000 employees. Our mission, I'll abbreviate our mission, but our mission is to eliminate disparities in healthcare access and in outcomes for underserved communities. That's our mission. And our vision is to one day be the leading community provider of services to those populations. But our strategic statement is what driving our research going forward. And I am going to go through our strategic statement so you really understand how it's important to align the research to what we're trying to create. So we have these these broad-reaching long-term goals, but our strategic statement outlines our goals for the next 5 years. And the first element is to be a 4.5-star CMS star rated group. That means we have quality and we have patient satisfaction, and we have quality in the measures that are agreed to nationally, with some moderate, we adapt them slightly. Growing to 350,000 members, so doubling our membership over 5 years. Evidence-based medicine, integrated medicine, culturally and linguistically competent care for Latino, multi-ethnic, and underserved families to reduce healthcare disparities in Southern California. So everything we do, operational and research, should tie to those specific issues around quality, patient experience, and improving the care of the underserved. So a little bit about the history of our research. So when I first came to Altamed about 5 years ago, and I'm going to lump research and grants because it's really a very similar process. So a lot of the research and grants were more opportunistic than strategic. And I'll give you a couple examples. So I inherited an HIV grant, a universal screening grant for HIV that was going nowhere. And it was going nowhere because there was no linkage for the providers as to why they were doing it. It didn't make any sense, except they're being told to screen patients for HIV. Once we made the connection that in our population it would soon be determined that it's evidence-based, the evidence was leaning that way. It wasn't an official recommendation yet. It was expert opinion that we should be screening our population for HIV, and then shortly thereafter it became evidence-based recommendation. Once that connection was made, that it was the right thing to do, that it was evidence-based, our providers got behind it, we put all the resources behind it, and our screening rates for HIV grew exponentially. And it was just a matter of making that connection. Similarly, we inherited another grant, I inherited another grant called the Berry Grant. Berry Grant was a great research project. It was about appropriate antibiotic use in populations. And it was a really good grant. It was a really good outcome, showing you could reduce antibiotic use by educating providers. But going forward, we probably would not have accepted the Berry Grant because it wasn't really aligned with us strategically. It wasn't focusing on any specific population necessarily. It was not reducing disparities. It wasn't about improving quality in the measures we're going after. So those are two examples of how we had some projects that were not necessarily aligned. Going forward, again, we're trying to tie it a lot more to our strategic statement. And to be attractive to researchers and to do good work, we knew we had to build up our capacity. So what does that look like? One is, having leadership, having medical leadership that can make the connection for the providers of why we're doing the research and why we want their participation in the research. And so one of the first things I did within the first year or so was I hired a medical director of innovation. Michael Hockman, who's sitting over here, will be speaking in a little while in another group. So having somebody responsible for this, and one of the things we've learned over and over at our institution, unless you have somebody responsible, it doesn't get done. So having somebody responsible for it has helped a lot. We have a growing research team, so we have a medical director, a research coordinator, evaluation coordinator, and as we get more research grants, research projects and other grants, having this team to coordinate and to drive the outcomes, the success of the program's outcomes, has been really important. We have a research committee. And we have a stakeholder review, and the stakeholder review occurs both with the research committee and with the medical leadership and the operational leadership. Again, asking these very basic questions related to the strategy. Is the proposed project relevant to our population? Is it likely to be evidence-based? Is it aligned to our strategic goals? And is it sustainable? Will it fit in our delivery model? One of the biggest frustrations any group has is if you do research projects that send positive, but you can't integrate it into your ongoing delivery system. And then the other things we had to do to build it up, and which made us very attractive to researchers, is we built up a nice IT infrastructure. So we have electronic health record, and we have a data warehouse, and we have an analytics team, so we can actually get data, mine data, and get good results, do good evaluations. And the other part is we don't really generate our own research for the most part, so we have important partnerships. And over the last several years, we developed strong partnerships with USC and UCLA in particular, but also UCI and the county public health department and others. So it's really important for us to do good research, to have good partnerships. So now what's going on with some examples of some of our current projects and how they relate. So now the universal HIV screening plan, which before was floundering, is now very successful. That project is done. We showed that we had very high screening rates, very high cooperation from the providers. We found lots of HIV positive patients. We've linked them to care regardless of their ability to pay. We've linked them to providers. We've linked them to drug therapy, and that again has been very successful. And in addition, it supports our own HIV programs. We have HIV programs in LA County and Orange County, and it supports those programs. So that was a real win. We're just finishing up a CMMI innovation grant with USC around clinical pharmacy. It changes our delivery system. It's helping us develop some care management teams. And it's been very successful in terms of provider satisfaction, patient satisfaction, quality outcomes, reducing total cost of care. And it's been so successful, we're trying to find a way to integrate it into our delivery system going forward. We had a care transitions grant around discharge planning for the Medicare fee-for-service population. It was never a population that we thought would be important to us going forward, but we knew that the learnings we would get from that grant would help us in developing our systems for the managed care population, one which is very important for us going forward. So again, something we learned from a project. We showed we could reduce readmission rates, and we're going to integrate that into our systems going forward. And then we have a couple obesity grants, both for children and for the community overall. And those are important for us to fulfill our mission of reducing obesity and the complications of obesity within our community. So all those that I mentioned now that we're doing now are really tightly aligned to our mission and to our strategy. So that leads to a couple examples of what we don't do. What we don't do is we don't do pharma grants. We don't do drug studies because it doesn't fit. Finding a new expensive drug to treat diabetes doesn't fit for our population. So there are a lot of groups do that for the profit. For us, it just doesn't fit our mission, nor is it sustainable in our population. And the same thing would be true of medical devices in general. Not good studies, research projects that would fit well with us. So just in summary, for us, research has to be tightly aligned to the mission and the vision and the values and the strategy of the company, both to be aligned, but more importantly, not just to be aligned, but be successful. If it's not aligned, it won't be successful. That's been our experience. I'm sure some of you have had that similar experience. It requires a dedicated infrastructure, and that infrastructure needs to scale to your needs. So we started very small several years ago, and our infrastructure gets larger and larger as we take on more projects and larger projects. It needs its own leadership to drive results, and the department has to have leadership support up and down the entire organization to be successful. So thank you very much.
While Ibrahim is loading up my slides, let me just ask, so I can target my remarks appropriately. How many of you are health system leaders? Raise your hand. How many of you are researchers? Okay. How many of you are clinicians? Trainees? Researchers who are health system leaders? One, okay, one or two. I'm sorry? Community member leaders. It wasn't meant to be a mutually exclusive, collectively exhaustive kind of list, but it's just helpful to me to know who I'm talking to today. And before I go further, let me just thank Greg for the nice introduction, thank Brian for inviting me to speak to you. And I'm not a health system leader, so how did I get on this panel of health system leaders? I'm going to tell you a little bit about a group that I work with and that I lead at Kaiser Permanente, and our whole modus operandi has been to insinuate ourselves into various operational work groups and to work closely with operational leaders. So perhaps this is another example of that. And again, I'm delighted to be here today and really going to address this theme of health system leadership and research from the perspective of a researcher who's been extremely fortunate over the last 4 years to have been able to build a very strong relationship with our leadership at Kaiser Permanente. So let me tell you a little bit about KP first, although I'm sure most of you have heard of us. The Kaiser part is a prepaid capitated health plan. Kaiser Foundation Hospital and Health Plan is one side of our organization, and they address the insurance product and the functioning of our 14 hospitals in Southern California. The Permanente part is the Southern California Permanente Medical Group. This is an independent medical group. It's a partnership. SUPMG contracts exclusively, more or less, with Kaiser Foundation Hospital and Health Plan to provide medical care to the members of our system. It's an integrated delivery system, so we can follow patients from the outpatient to the inpatient setting and into long-term care settings as well. We have comprehensive electronic health records. It's been in place since 2006, 2007 in our Southern California region. And my own take on the values that I think are defining, if not unique, characteristics of KP are a real appreciation for quality, a more recent emphasis on affordability, and partly because of the way we're structured, there's a very, very strong sense of physician autonomy and much less managed care than one would expect in something that came to life as a managed care organization. So I would describe this as managed care with a very small m. We have almost 3.8 million members in Southern California. We operate 200 medical offices, 14 hospitals. There are 6,000 physicians, including both partners and associates, and 20,000 nurses, 60,000 employees. So it's a very, very large, complicated, fascinating, dynamic, rich environment within which to be a researcher. And part of the challenge for me and our team coming into this system was to figure out how do we navigate through this very, very rich and diverse environment. How do we find the right partners? How do we identify the right projects? And how do we kind of get on the map so that people know that we're a good group to work with? Because we're a very, very small research department. We're a small team within a small research department within a very, very large care environment. I sometimes refer to our group as a dwarf planet within, the much larger solar system. Our department, we have 30 full-time research scientists. Several of them are here today. We have over 300 support staff. We're located in Pasadena, not in one of our hospitals or medical office buildings, but just down the street from our regional offices. We're officially employed by the medical group, but we do have sponsors on both the medical group and the hospital health plan side. We report to the medical director for quality and clinical analysis, who's one of our visionary leaders. The two things that make KP an incredible place for a researcher like me, a health services researcher, to work. One is our comprehensive research data warehouse, which draws on data from our electronic health record and pulls in information from multiple other sources to provide, again, this longitudinal view of the care experience and our ability to actually study it. But increasingly, we know that we're not the only ones who have electronic health records. We're not the only ones who have an integrated health system. And we think of our strategic advantage as being researchers who are embedded in a delivery system and who are able to use that system as a laboratory for creating generalizable knowledge. Our team within the Department of Research and Evaluation is called the CERT, or the Care Improvement Research Team. We were created by hospital and health plan leadership in 2013. our goal is to improve care and increase affordability for our members. We also, again, want to create and share generalizable knowledge, so everything we do is published in the public domain. And as I mentioned a minute ago, our real challenge and what's been so much fun is to figure out how to weave research into the existing fabric of clinical care and quality improvement, when we are one of literally dozens of groups that are engaged in care improvement, quality assurance. And increasingly, we're interested in, again, using our care environments as laboratories to generate practice-based evidence and thereby fulfill the potential of the learning healthcare system. That's a lot of jargon, but I actually really believe that. So our mission is to enhance the health of individuals and populations through systematic study of ways to improve healthcare delivery. And the key part of this is the collaboration. We can't drive this agenda and we can't do this work as researchers alone. I can do observational studies using our data, but if we really want to perform interventional studies, if we want to test out new models of care, we really need to partner with our clinicians and operational leaders, and increasingly with our members and patients, so that they can inform the projects that we choose, the outcomes that we measure, and the approaches that we take. We want to be the model for embedded research within a learning healthcare system. So how do we do this? Again, the partnerships is really crucial, and I think a good percentage of our activity in the last 2 years has been just building relationships, just showing up at meetings with different operational work groups, listening in, finding out what the important problems are from their perspective, and then providing little bits of help along the way. If we can provide some content expertise, if we can provide some methodological rigor. And we have to be, and frankly, I've been very careful about not stepping on toes and not being a bull in a china shop about, imposing the rigor of research on a health system where sometimes good enough is not only good enough, it's exactly what we need. So it's a little bit of a balancing act. Our own program, we're trying to create this virtuous cycle of internally focused and externally funded research, and we're aiming for about a 50-50 balance. And we're also very pluralistic when it comes to methods. So we're doing observational studies, qualitative and mixed method studies, so that we can understand reasons for gaps in care, and then do some quasi-experimental studies and pragmatic trials to close those gaps. Our sponsors, again, going back to the theme of health system leaders, I would say that it's an incredibly enlightened and supportive group. Dr. Chu is our president and CEO in Southern California, and he's the one who had the vision to create our program and provide our resources. Nirav Shah is our new chief operating officer and executive vice president. He's a very hands-on, active, day-to-day partner who we have really great opportunities to interact with. And on the medical group side, Michael Cantor, our director for quality and clinical analysis, is someone that we meet with monthly to share ideas, provide updates about our projects, and find out what are the issues that are important to our medical group so that we can help them with projects. And then the senior director of our research department is also a key sponsor. The resources that we've been given financially in terms of hard money support have allowed us to hire about 3.5 FTE of research scientists and about 6.5 FTE of support staff. We have some other external funding to support additional personnel. Some members of our team are here today, Shana and Brian. This is what I think made a difference, and this is really the key slide, so the rest is just background. So how can health system leaders build or harness and leverage some of the skills and tools that we have as researchers? Well, one, they made a hard money investment in our program that's allowed us to step away from writing grants at least part of the time and concentrate on, again, problems that are of importance to the health system. Even more importantly, they didn't just give us the money and then walk away, which, you know, for some researchers that might be nice, but for us it's really crucial that we have the access to our operational leaders and decision makers, so that we can be part of the so building on Dr. Serota's theme, we can be responsive to the needs of our system. They've also steered us away from certain projects and towards others so that we can avoid certain pitfalls, and they've been very helpful in facilitating relationships with the different groups that work within Kaiser Permanente Southern California, our clinical chiefs of service, our technology assessment program, a whole small army of people known as our improvement advisors, and several other teams. We have 24 or 25 projects that are currently ongoing in a whole variety of different areas. The key ones are cancer care and survivorship, chronic disease management, overuse of imaging and other low-value care. And these represent areas in which our interests as researchers intersect with the larger goals of the health system. So we didn't just choose these randomly. This is something that fell together more naturally. And again, we're interested in addressing the larger Kaiser Permanente priorities of reducing unwarranted practice variation, improving affordability, and helping to transform care. So these are the challenges that we're facing, and I'd be happy to discuss any of these during the Q&A. We're, again, a small program with limited bandwidth, with 25 ongoing projects now and a couple of externally funded projects that have come through recently. We're really at our limits. So how do we scale up, and how do we leverage our partnerships so that we can do more? One thing that keeps coming up is how do we choose our projects? What comes to the top of the list in a system like many others where the needs are great and, you know, again, the resources are somewhat limited. Some of our infrastructure, as enviable as it is to have the comprehensive electronic health record and the research data warehouse, it's really not geared to support rapid cycle research and real-time decision making. So how do we build on that? And then there are some really, really interesting things about the organizational culture, not only within KP, but I think in any care environment. When you're working with busy clinicians, and this came up in Dr. Khan's session this morning on the CMS imaging project, how do you encourage people to participate in interventions and projects that may or may not improve their efficiency and their ability to provide care? How do you get them out of well-established routines and encourage them to do something that's a little bit different, especially in this culture where physician autonomy is very important, where there are informal communication channels for decision making, and where it's often difficult to reach consensus, and where we have 4,000 partners, any one of whom can say no and put the kibosh on something, and very few people who can actually say yes and make something happen. So I'll end my remarks there and look forward to the Q&A. Thank you.
Okay, so I think the format is we can have questions for any individual or all panelists, and we have folks roaming the audience with microphones, so any burning questions or just smoldering questions? Well, I'll start. I'll start with Michael Gould. You were last up. So a lot of what we heard was about collaborations, but within a bounded system. Can you talk at all about collaborations with researchers or community partners outside of Kaiser?
Yeah, so I can address that in a number of ways. So first of all, we have opportunities through the networks that we participate in to work with other KP regions, other integrated health systems, and increasingly the rest of the world, and most of the rest of the world is not an integrated system. So we're involved in PCORNet and the National Community Oncology Research Program, amongst other larger collaborative groups. Frankly, those are creating both opportunities and challenges for us in terms of there being pros and cons of sharing data with others and developing governance structures so that we can do that and not only maintain confidentiality, but we have a certain vested self-interest in having first crack at our own data, so to speak. Regarding community partnerships, KP's membership is about 20% of the Southern California population, and so there are a number of other groups within the organization that work with schools in Southern California, with various other groups in the community. And I would say part of the future planning for KP in general, not necessarily research, we're just following here, is to bring care outside of the four walls of the hospital and the medical office building. So how do we reach our members and how do we reach communities? There's another KP-wide initiative that's just beginning now, addressing the social determinants of health, which kind of put us in your sandbox. So how do we address the needs of our members and the needs of communities for housing, to address food insecurity and other issues like that? So it's something that's on our radar. It's kind of bigger than our small group within research can actually take on at this time. But I think it's a direction that our system and that we would like to move in eventually.
Okay, great. Right back here.
And it occurred to us that under our portfolio, we have these two groups that both research and community benefit. So I was really encouraged that you did that. How do we address research as well as outreach?
Yeah, so thank you for that, and I should thank you and Community Benefit because you provide a lot of our funding. So I didn't call out Angela Caron specifically, but she's one of our important sponsors.
So let me just ask Alfredo about the role of community advocacy, and does that shape initiatives within the county behavioral health system, and is there a reciprocal influence, or how does that come about?
Yeah, I think in most counties, I think we really have looked at a recovery model for adults, a resiliency model per se for children and youth, and in those models, the voice of the consumer, the family member is paramount in really developing our services. So as we move into partnership with researchers and evaluators, we want to mirror that. I had commented earlier that I was talking about our research committee and how we weren't following our principles. And when I was kind of studying up for today, I realized that. One of the things that I was thinking of when the question to Kaiser was, what's really interesting about San Diego and what I did not experience in the Bay Area is many times people that work in public systems or hospital systems feel that researchers and evaluators are imposed on them. The state will say, we want to evaluate the county's public health system or the mental health system, and all of a sudden at your doorstep is a researcher evaluator, and right off there's not that kind of, is more of a defensive, reactive experience that one has with a researcher. I know there's a lot of researchers here. I think and that's what we experienced in San Mateo, where I used to work, where University California, San Francisco did a system of care study, and it was somewhat imposing. They got a grant, and your county is the subject. And while in San Diego, what's been great is this partnership. So when I talk to my staff, they know we're invested as managers, as staff, and our consumers are also invested. So when we talk to Greg and others about doing a research study or formulating some kind of evaluation program, we do it together. And I think that's critical, I think, in the success of a program. And also, so all of you that are doing research don't have the door slammed in your face or feel like people are, just not responsive to what about the important work you need to do. So, anyway.
Okay. Question right here. Here comes the mic.
And I represent community. And I'm glad to hear what you said, because a lot of times researchers do come in the community and they research us, and we don't even know who they are. We've never seen them, and they just start asking us questions, or they call us on the phone. We don't know who they are, so we hang up. And so you don't get your research that you need because you have not thought of us as an equal partner. And that's frightening to us as community, because we don't know what you're talking about. We don't know why you're doing it. We don't know how it's going to benefit us, or is it going to benefit us, but we know it's going to benefit you. And so one of the things I try to do is let researchers know that if you're going to research people, they're people. They're not subjects. They're participants. I know that's a big argument. And so participants are live people. And so you have to treat them like people. And you have to talk with them. You got to collaborate. You got to communicate. And so when you want to do a research project, might think about bringing community aboard. If you come up with an ideal and say, hey, let's go and ask so-and-so to bring someone to the table with us to explain what you're trying to do, because we can bring those other people in that you want to research. And then we can make it comfortable for you to be there, for us to be there as a team, because we're partners, community, participatory, what's the word? Partnered research. Thank you.
Good point.
Question over here. Back right there.
Thanks for such a great presentation. Trying to kind of figure out it seems something that was consistent across the presentations were at least the kind of notion of leadership. Kind of leadership, as I would take it, kind of taking initiative, taking charge, having a vision, enacting changes. And I was wondering, particularly with the presenter from Altamed was mentioning, leadership at all levels. And we typically think about leadership, at the highest managerial level, the director taking on some task or, sharing a vision. But as we think about implementation of this new practice, I wonder, how does that leadership at the lower levels look like in your experience when you're working in these systems? What are examples of somebody, case manager, taking on a leadership role or enacting leadership to be able to kind of move forward, or community residents, community members taking leadership to move forward a particular initiative?
Okay, so I'll take first stab at that. I'm going to follow up on something Michael said, which is he said it slightly differently, but it takes 1,000 people to make a decision, but one person to stop it. And that's probably true in most institutions. And I think that's part of what you're addressing. So It's higher leadership's responsibility to make sure there's alignment and to routinely drive for outcomes. So you build success builds upon success. That's the higher leadership. And their responsibility is also to make the connection. And as you cascade this responsibility down through the entity, it's each leader's responsibility to cascade to the next level down, what's in it for them and what the connection is. Because without that connection, they're not going to buy in. So it doesn't really matter what level you're operating at. You first have to understand what it's all about, why you're doing it, and then communicate that to your peers and to the next level down.
Just a couple quick examples of leadership. I think it's critical when you have the opportunity in any system is to involve line staff. We had 2 examples of that in our county. The Substance Abuse Mental Health Services Administration had put out a request for interested communities to be a learning community for trauma-informed care. And we picked one of our county-operated clinics that provide outpatient care to be involved in the study. It was a year-long, basically, learning academy. And it involved everyone from the front desk clerk, receptionist, to the chief psychiatrist of the unit, to the managers of the clinic. And also we have primary care, FQHC as a neighbor, and we actually began to share some of their experiences because people perceive that as an overall health clinic, not just the mental health part of that, the wing of that facility. So they were involved, and also another example was we involved our county lead, our county line staff, case management staff, to be involved in ushering in a strength-based case management program. Again, we participate as a learning academy, as one of many counties have participated in an effort led by the California Institute for Behavioral Health about 2 years ago. And again, that's where you get buy-in, and it's not felt like it's imposed by management, but they're part of really developing the model.
Right here.
Hi. My question is for the behavioral health leaders. I was wondering, do you guys, with your projects, do you ever invite the K through 12 educational leaders that work in those programs that deal with the populations that you would be servicing to the table? Because I work with, like, I teach a special ed, the pregnant minor program, correctional ed, Head Start, court system classrooms. And many times we're going to be working with that population that you are servicing. And I find, since I've been involved with the research, we're not at the table, and we have the connection to the people in many of the communities and the children. So do you ever invite educators from K through 12 systems?
Absolutely. Both in my prior county and in my current county, when we were developing systems of care for children, youth, and their families, the special ed sector in particular were a key partner because the counties were serving, as you know, special ed children at the time. And so they became a collaborative partner, part of our public sector partnership in both counties. Another example of, and it's really helpful when you have a unified school district that has a mental health a mental health service center. LA County has one, San Diego Unified has one, Fresno. I think there's probably a half dozen school districts that actually have their own mental health programs. These are school employees that provide mental health services, and typically they work very closely with the broader public mental health system. And in those cases, like in LA, Fresno, San Diego, they've been an integral partner in the developments of systems of care, along with the research and evaluation piece to that. But absolutely, they're a key partner. Got involved from the front end. Thank you.
Okay. Other questions? Right here.
You all have sort of alluded to this, but how do you make the business case to your leadership for embedding research, as you were saying, Michael, and we've tried to do at Altamed, into the health system?
So I'll take the first crack at that. So I was serious when I said we had enlightened leadership, because this opportunity kind of fell in our laps. We didn't need to do much in the way of lobbying. Now, I think we had, certain advantages going in, the wind blowing in the sail, so to speak. We had an existing research department that, at least historically, was focused mostly on classical epidemiology as opposed to health services or care improvement research. KP aspires and in many ways aspires to be and in many ways exemplifies the learning health system. So, and there is a strong culture around learning and improvement. So I think all of that kind of came to a head, and our senior director in his conversations with our hospital and health plan leaders was able to build this case. But I was kind of in the right place at the right time and had a great opportunity.
Other comments?
I'll just make one quick comment. I've been a cost center and I've been a profit center, and I like being a profit center a lot better.
One thing I want to mention too around leadership is it's research and data's and science's relationship to public policy. I'd like to say that all three of us represent systems that still believe in driving public policy with actual science and research, as opposed to ideology and rhetoric, which you often see on CNN and Fox, whatever you watch every evening. And so, I think that's a key part of leadership is, driving decision-making and how we operate our services, again, based on data. Right now, we have a major challenge in front of us in behavioral health. The life expectancy of someone with a serious mental illness is 25 years less than the average, to the national average in terms of life expectancy. That is unacceptable, and I think that's the challenge that's facing us. And that's data that, there was a recent set of data that just came and confirmed it again. It's really challenging us to figure out, okay, let's work with this data and what can we do to turn that around. Of course, a lot of that's access to health care, and under the Affordable Care Act, I would hope that you'll start to see changes in life expectancy for people with serious mental illness.
So could I go back, because I actually had another thought about Michael's question. So I think the big picture response to that is to build the case that a research unit or a research group can effectively serve as the R&D engine for learning in the whatever your system happens to be. And you think about any Fortune 500 company in any other industry, they're pouring 20% of revenue or whatever it is into R&D. And I think historically hospitals, and if they did it at all, the idea was that pharma and other external groups were driving the innovation, and that those innovations would be available on a shelf. We could just pick and choose and then put them into place. And it kind of reflects the overall transformation of healthcare from a cottage industry into something that's more mature and more fascinating. But I would make that argument that we, as health systems, as hospitals, we need our own R&D engines to know how to do things better. It's not going to happen by itself, and it needs to be addressed systematically.
I think we have time for another question. It's on the tip of your brain, on the tip of your tongue. Now's the time. There we go.
I actually, oh, sorry, I was a little loud. I have a question for, I think it's Alfredo. Mm-hmm. Alfredo? You were mentioning earlier about the new initiatives that you're going to be doing, and it has like a group, there was like a list of groups, and there was a few in there like faith-based and youth, and I think older adults. And so you mentioned that you're having evaluators come in and evaluate the outcomes of these initiatives. Could you talk a little bit more about that? What does that look like? And are these evaluators, external evaluators coming in And also, with the initiatives that you're doing, are these people who are from the community, or are these actual patients, or how
Okay.
say a little
Yeah,
bit more?
so these are innovative projects, and we actually have an RFP out into the community for a research and evaluation entity to come and evaluate. It's twofold, really looking at the more qualitative, what is the practice, really documenting the actual practice and its techniques, its approaches in addressing a problem that has not been sufficiently addressed in our current system. So we identify an issue, a need, and then we employ a new practice. And the evaluator will determine what that is and what kind of impact it had in terms of various objectives that the program will outline. Obviously, a hoarding project, you want to see reduction in that behavior. And actually, San Francisco, I know, has done some really good work. And so we're kind of taking something from what we've learned from San Francisco and applying those core features of that program here. So yeah, we, again, driven by the data that we have, and as much as we've developed our systems, we've identified particular areas where better work could be done, or a new type of work can be done. So that's what we'll be doing.
All right, so I just want to thank our panelists and all of you for your great questions. And now I want to invite Greer Sullivan up to moderate the next panel.